Hi, everyone. You are listening to Vulva Views. I'm Allison Chawla, psychotherapist and alternative healer.
And I'm Amy Novatt, MD gynecologist.
Thank you for tuning in again. I just want to remind you all, if you're enjoying our show, please give us 5 stars. Come follow us. We're easy to get in touch with if you have any questions or comments. I would also like to take a moment to thank our producers, Jen Hamoud and Maddie Rosenberg, who help us here in the back of the Epicurean in Rhinecliff, New York, in this fantastic little magical studio that we have the privilege of recording in.
Today, it is kind of magical.
It's
Sorry,
magical.
I had to interject.
Please interject. It's magical. It's a special little nugget in the middle of the Hudson Valley.
Morsel. We're one of the many morsels in the
I'm going to go with nugget
story.
because it reminds me of gold panning.
And I think of morsels because there's chocolate chip cookies out there and chips and all kinds of things.
Both adequate. There's so many circumstances and so many symptoms and diseases and struggles and disorders that people deal with that I find and have observed are incredibly misunderstood in the world. And unfortunately, because of that misunderstanding, there's a lot of judgment that is put upon those who are struggling. And so today we have an incredibly brilliant guest that is going to speak about a topic that I not only have heard many people most certainly misunderstanding and criticizing others for, but a subject matter that myself as a clinician would like to learn more about. And so with me, I have Tabitha Limotte. Hello, thank you so much for joining us.
Welcome.
Thank you for having me.
And Tabitha specializes in eating disorders in her therapy practice. Tabitha, if you'd like to take a moment to give us a little background about your credentials and what led you to this path.
So, I'm a family therapist. I did a internship when I was I think it was actually an undergrad, at a treatment center in Los Angeles for eating disorders. And I ended up becoming a therapist, and I was there for about 10 years, both in Los Angeles, then started a program in New York, and became the clinical director. So most of my career as a therapist has been working with clients who have eating disorders. I left for private practice probably about 9 years ago, or 8, I guess, when I had my child.
Okay.
Yeah.
I'm really happy that you're here because I've noticed over time, over decades, that when someone observes someone that has an eating disorder that isn't trained, the perception is, oh, they're crazy. Look how thin they are. Oh, how could they think that they're fat? But there's so many more layers and reasons as to why someone develops an eating disorder. It's not necessarily just body dysmorphia, which is, well, maybe you should define body dysmorphia for those who may not understand it.
Well, I think the sort of easiest way to describe it is that your perception of your body, not just visual, but also your sort of lived in perception of your body is maybe too pliable, or it's distorted. So it's not so much that somebody looks in a mirror and they're emaciated. I think the sort of caricature of it is that you're emaciated, you look in the mirror, and then you sort of see yourself as being overweight.
Right.
But it's much more complicated than that. It's a little more like a sensory experience of the body that it's almost like the person has a hard time kind of making sense of, where their body starts and ends. And so it's gets kind of, I guess, distorted in their mind during different moments. There's a relationship between how one experiences their body and the other things that are going on in their life. So usually somebody will have, any kind of, let's say, crisis, or let's say a flare-up of anxiety, and people who have, body dysmorphia, though, is a separate disorder than eating disorder.
Right.
So that's kind of going to another track. But people with eating disorders generally have distorted body image, which is, I guess, separate from body dysmorphia.
Okay.
But there is slight relationship there.
So, eating disorders is a kind of the overarching umbrella, right? That
Yes.
describes a number of different phenomenon or diagnoses. Can you help us just understand maybe the major ones that people often think about? Yeah.
So there are three main eating disorders. There's anorexia, bulimia, and binge eating disorder. There are two others that are sort of newer categorizations that are less known, but still, worth talking about. There's something called ARFID. I feel like people know generally something about anorexia and bulimia and binge eating disorder. So do you want me to go into like the kind of what is the diagnostic criteria for those things, or like what's
I think maybe just for the listeners, a general description of what each one means.
Okay.
And then the other thing that I'm glad Amy asked that. The other thing that I really also want to ask you about is the things that cause eating disorders, because so many think, again, that it is about just the way someone is perceiving their bodies or wanting to lose weight. And I learned from you, as a matter of fact, that it can be something like an anxiety about the way of the world, and then that is how it ends up being channeled.
Yeah. So, anorexia is characterized by a person's intake is lower than what their needs are. And so there's usually a pretty significant weight suppression that they experience. That's the main, there are specifics about the criteria. It's below 85% of ideal body weight. And it's characterized by a preoccupation with food, body, and, sort of exercise and calories. Bulimia is when a person consumes large quantities of food and then they use compensatory behavior. So it could be exercise, could be vomiting, could be laxatives, and a variety of different things. It could, it could also just be cycles of extreme restriction and then, higher levels of consuming. And then binge eating disorder, which is really, it's not just overeating, it's really eating, higher amounts of food than would be expected and a sense of feeling out of control in that process.
I have to ask, what were those two others that I'm just
the
curious
two
what
others.
they
Okay,
are.
so there's one called ARFID, which is sort of like newer in the DSM-5, and what it is it really looks a lot like anorexia. So it's a person they're generally going to be underweight, and they're going to have some kind of restrictive eating pattern, but it's not motivated by the desire to lose weight. So this is often seen in younger children who show up to treatment. It's related also to people who have higher levels of anxiety, so OCD or autism, because there's sort of a sensory component. So clients who have ARFID it's almost like they just lose their appetite altogether. Food becomes kind of repulsive, but they don't really have a sense of why that is. They're not driven to lose weight. So we see more and more of that, actually, though it's not as common as something like binge eating disorder or bulimia or even anorexia, which is the least common of the main three eating disorders. Sorry. So let's see. Oh, and then the other is sort of like a catch-all diagnosis called OSFAD, which is really more about eating disorders that don't fit all the clinical kind of criteria for the other eating disorders. So that would be something like atypical anorexia, which is it's essentially a person who doesn't meet the body weight criteria for anorexia, but they still have a restrictive eating disorder, and they may be weight suppressed pretty seriously for their body, but just because everybody comes in different sizes, their body just isn't going to get to those lower weights, but they can still have pretty serious medical complications.
Interesting. Can we go into the causes for eating disorders? Because again, a lot of the reason that I think Amy and I do this show is not only to support people that are having the experiences and struggling with the experiences that we are discussing, but to help diminish things like judgment and misconception and support other people in understanding those around them best or better that are having these experiences. And I really found it fascinating when you explained to me in such an easy way to process that sometimes it can just be a hyper-focused anxiety that turns into this behavior.
Yeah.
And it has nothing to do with wanting to lose weight necessarily.
Yeah.
So can you go
Well,
into
there are
that
different
a bit?
theories about the causes. They're sort of like multifactorial, but I think an important thing to know is that there's sort of like a genetic and physiological vulnerability that exists there. And it sort of meets the cultural and social kind of dilemma that we have, that sort of like idealized thinness, a kind of abundant food environment, and a really kind of nutritionally complicated food environment about
You mean that a woman's body is not enough, that it does need some change, or it needs pinching or squeezing or getting tighter, which is something that Allison and I talk about. Yeah.
Yes.
It's so pardon me, I had to interject
Yeah.
there. A little
Also,
sarcasm.
I was also surprised at how many men have eating disorders.
Oh, yes.
as
Yes,
well.
it's
Yeah.
not just women.
not just
It's
women.
true.
Yeah.
It's true.
Yes, and growing. I think if you, there's at conferences, there's always talks about kind of this like wellness culture that men can kind of get lost in, and sort of a bodybuilding thing that, especially for younger men, can be pretty problematic. Different sort of supplementation and steroids and things that can be high risk behavior. Okay, so to the origin. So there is like a vulnerability kind of profile. And then it's sort of meeting these social and cultural things. There's a theory that dieting is kind of the entry point. So, it's pretty normalized to restrict your calories. So the idea is that the average person could go on a diet and then they just stop the diet. But a person who's vulnerable to developing an eating disorder, especially when we're talking about anorexia and bulimia, they would sort of be more vulnerable to those genes turning on through the process of dieting. So, their brains react to this process and their bodies differently than the average person. And once a sort of process of brain changes and gut changes and other physiological changes that a person undergoes during calorie restriction, they get kind of locked in to that,
Like a cascade, if you will.
Yeah.
So it's like the restriction of eating turns on or triggers the genetic propensity, which thereby then leads to a change in the way the brain, the body responds to foods, etc.
Yes. So then it becomes hard. They can't just start eating normally again because
I just wanted to ask, just to put it in different terms. So what you're telling us is that this can be inherited, essentially, or is a part of the DNA that can be passed on and triggered?
So there's not like a specific gene for an eating disorder, but it's usually things like sort of temperamental vulnerability. So a person with like higher trait anxiety, a person who, maybe it could even be a person with like, there's lots of different profiles, but a person who is like more sensitive GI wise, and then they might be more vulnerable to kind of getting locked into these things because they have this whole experience physically. And for any human, if you restrict their calories, and there's like really interesting research on this, there's this guy, Ansel Keys, who did a study of, I guess, conscientious objectors. And basically these guys who didn't want to go to the war, he had them participate in the study, and he was trying to look at what happens to the body when you starve it. And basically the study is like a profile in what happens to the brain when it has an eating disorder. the men, these were like, 18, 20 something year old men, college students, and they become preoccupied with food. They hide food. They over-exercise, which you wouldn't expect, but they were locked into doing this. They didn't have access to other food. So they just became kind of chronic movers who were obsessing with food. Then once they started to, I guess, refeed them, which essentially was just like, okay, now you're done with the study, they all overate. And they all gained lots more weight. And some of them had problematic eating behaviors ongoing. So, it's almost like there are physiological changes that kind of lock a person into this. It gets really complicated to try to change that. It's not just a matter of the behavior changing. It's, even though that's a critical part of getting well, they have to do that for long enough for the physiological changes to, to like reacclimate their body to eating normally, basically. And that's a long process.
Yeah, it so reminds me, it's kind of one of the reasons that we do Vulva Views, so that Allison and I can kind of mingle the psychotherapeutic perspective with the medical or physical perspective. And it's, what you're pointing out is this kind of incredible paradigm that, again, is about the mind and the body and the mingling and the intertwining, and often the inability to kind of just, like, you just can't take one away from the other. They're co-conspirators, if you will. Yeah.
It's really interesting what you mentioned about children, and this just was very profound to me, that a child can develop an eating disorder because it makes them feel safer and in control, and I think of children that have like irritable bowel, or many children, it's very common, they don't want to have a bowel movement because they think it's a part of their body exiting, and it's a very unsafe act. And then knowing that if you eat, you will likely have a bowel movement. And so therefore, the fear of the bowel movement, for example, overrides the desire to eat. And that in itself is a form of an eating disorder. But it's not, again, it's just shifting the focus and the idea of what this actually means and why it happens to people.
Yeah. So the cultural story of the development of eating disorders, I think, it's a tough one. It clearly plays some kind of role. And there is research that indicates that. There was this woman named Amy Becker who did a study of the introduction of television to Fiji in the 90s. And so it was kind of this natural kind of experiment in the sense that nobody had TV. And then they gave a few TVs, or there were a few TVs, kind of introduced into the community. And the incidence of disordered eating went up. And I think the part of the study that's so fascinating is that you didn't have to own a TV to have that impact you. So it was like, just once the ideas are out there, like, we're starting to take them in.
The collective unconscious.
Right. And as we were talking about this the other night, that eating disorders can be contagious.
There is this is why prevention is so hard, because there's this kind of social contagion aspect of it. And similar to the way there were problems with, like, I don't know if you like the DARE program that was supposed to teach you.
Yes.
And then they found that it actually like made kids more interested.
Horrible.
But
true. I remember that. I remember being like,
prevention for eating disorders, when you just go in and try to give a list of symptoms and kind of, detail the disorders, it doesn't seem to actually do much good. So the prevention that seems to be most effective is a sort of media literacy type of program. So things that sort of teach you to think about, like, the thin ideal, what's your relationship to that? What are the problems with that, to kind of critique it. And I think that could be folded into just like a broader media literacy kind of program. Like, what are the messages you're receiving? I mean, even now, like, the stuff that kids are exposed to, it's not even just about thinness or appearance. It's kind of like it's about this kind of pristine kind of wellness kind of stuff. It's like just the nutritional kind of confusion, I think, is pretty wild.
I've seen it also, again, sorry to bring up social media again, but here we go. It's also, there is some influence of popularity. There is a young woman, I'm forgetting her name, but she has some of the most followers because she is severely anorexic.
Oh, yeah.
But she has a personality online and she dresses herself a certain way and she prides herself with this skeletal figure and a very unique way of dressing it. And she has millions of followers. And to me, I mean, that is just not a healthy message to, regardless of what the poor thing is suffering from that's causing this.
Yeah.
I think that people will want to mimic her.
Yeah.
In contrast, there's an influencer who has been a very full-bodied young woman who had a lot of followers because she was very supportive of kind of all body types. And she started losing weight.
Yeah, I just read that.
And the feedback around it, the vitriol that was thrown her way, saying, "Oh, all of a sudden you're body shaming those of us who are full bodied." I mean, she couldn't win. She just couldn't win. She wanted to pursue health for herself.
Yeah,
and this was one of the ways she was doing it. And then she was just criticized. So it's, is it confusing and hard for?
Yeah. Well, even like that's sort of pointing to the problems of like the body positivity movement, which it still centers the body, you know?
Right.
And so we sort of, in treatment, it's really more about, body neutrality, just like seeing yourself as a whole. You're a whole person. You have all these other things going on, how can you regulate your relationship to this idea? It's not that you're, going to never think about the way you look or that you're not going to have appearance concerns, but that you can tolerate that you maybe have some dissatisfaction, but it's just not taking up as much real estate in your mind, that it's sort of like this is only one piece of a whole story.
I'd be curious for both of you, when someone with an eating disorder comes into your office, are they coming in to talk about their eating disorder, or are they more often talking about anxiety or depression or things that are happening at school? Like, is it even unknown to them that this is a phenomenon and it's only identified after they've been in your office and you're like, wow, that young lady, for example, is extremely thin? How does it come into your office? Because I know how it comes into my office.
Well, this is Allison speaking, because there's a few voices. I want to be clear. I do not work with people with eating disorders.
How does that
Because
happen?
I'm not specialized in it. And it's something that you have to have specific training for.
Got it.
So if someone comes in and it's very obvious to me that there is an eating disorder, I support them in referring them and transferring them to someone that specializes in eating disorders.
And will you put that, if you will, pardon me, diagnosis out there and say, I am referring you because I think you have an eating disorder? How does that happen?
Not necessarily. There's a lot of boundaries that have to be in place, and it's a very delicate demographic group. And so usually I don't say anything like that, or I will say, I don't think I have the specialties or the skills that you are in need of, but I have someone in mind for you. Would you like me to refer you to them?
Yeah, I like that.
Would you like me to make the intro? Even, help, I'll talk to them first for you. Whatever they need. So it's never about what I want to do or what I see. It's about how can I best get this person to who they need to be with.
I so respect that, Allison, because so often in the world of healing, health, medicine, even psychotherapy, it's about, I'm going to give you a diagnosis and this is what defines you. And it's so ensnaring. And I personally, professionally, I just don't see it as helpful. Certainly not at the beginning. There may be some value in giving it a name at one point during treatment, but that initial, like, I've stamped you this, and it's just so I just see it as punitive.
Yeah, and a diagnosis is also intended to be very helpful for things like understanding and making a plan, and also getting your insurance to help you if you can't afford therapy. But I never make it about myself. And even if I do know, this is clearly an eating disorder, it's more that I am not the right person, and I will be harmful if I try, because I'm not skilled in this area. And so I need to find someone that is. So, for example, if I were to send them to Tabitha, what's your next step?
I very rarely get a client who isn't fully aware that they have a problem with food. It has happened. When I worked at the treatment center, there were times where people would admit to the program they were forced by family members, and they were just sort of like, I don't even know why I'm here. In that case, and also just when somebody's coming of their own volition and they're fully aware, a lot of the work is about motivation. It's really motivation for behavioral change. So I consider myself to be more of a cognitive behavioral therapist.
What does that mean? Remind the audience.
So, as opposed to like a psychodynamic or psychoanalytic therapist, I'm really more focused on kind of the immediate. And there's always a sort of generally a target behavior that we want to change. And we're working on sort of figuring out what's getting in the way of them making this specific change, things that they sort of lay out as their goals. I might have some influence in that, but so it's a little more, it includes reflecting on, maybe your childhood circumstances and different things that have happened in your life, but it's not exclusively that. It's really about, behavioral change. And that's just a product of, I think, my, my temperament, and also the kind of work I've always been in, where it's like short-term care at a treatment center. We have X amount, we have 6 weeks, and this person has active symptoms. So eating disorders really lend themselves toward, okay, we're going to try to address this symptom, and here's our plan, and I like it because you actually can kind of get to like a result, and I think sometimes like long-term psychodynamic therapy is just a different animal in that way.
Yeah. How successful are these treatments for the eating disorders?
It's a good question. They're very hard to treat.
Yeah.
There's a high relapse rate. I mean, it's an addiction. It operates very similar to addiction.
Yeah.
There are, in my opinion, there's like a glut of programs. We started, I think, in the like early 90s. There were like 2 across the country, and now there are hundreds.
And we're talking about inpatient clinics.
So there's inpatient, which would be at a hospital. And there are fewer of those programs, but they exist. And then there are residential level of care, which there are a number. I mean, access to care is a problem, but it's a lot of these programs can't take a ton of people, but they're also prohibitively expensive. So, so they're residential care. Then there's day treatment programs and intensive outpatient programs. So there's sort of like a whole suite of care, and then just individual outpatient therapy.
Yeah.
So their effectiveness, I think, I don't know like the actual data on how many people recover, but what I do know is that they're usually long-term illnesses, and especially when you're talking about anorexia, it does have a pretty high mortality rate for a mental illness. Half of that is really accounted for by suicide, but there's also the instance of alcohol and anorexia is pretty lethal. There are people who have diabetes and anorexia. It's a very high risk population. But there are lots of stories of women dying in their 20s and 30s from, heart failure.
Yeah. It is remarkable. I had never really thought about it being kind of a chronic disease like alcoholism until, well, it's now a couple decades. And the reason it struck me was I had a middle-aged woman come into the office who said, we were just going through her history, do you have a history of this or this or this or this? And she said, I have a history of an eating disorder. And I thought, so I asked, well, when was that an issue? And she was like, oh, when I was 14 and she was 52 or something like that. So it was years and years past. But she felt very compelled, and now I understand why, to make sure that I understood that diagnosis as much as a history of diabetes or a surgery or whatever, that it felt very much defining for her. And I value that. I think it's so important.
Yeah.
I wonder, because I'm sure people listening are now developing a different level of awareness and maybe concern, particularly those with young children or teenage children. Are there very obvious symptoms that can be spotted even if the individual suffering is trying to hide them beyond the weight loss?
Good question. Yeah.
And weight loss is, it's not always there.
Right.
That's
why
a
I'm
person's
asking.
body is not really the best
Gauge.
It's a little tricky. You might notice there are usually some personality changes. If we're talking about somebody who's, pretty active, I think you could notice, a change in kind of eating behavior, willingness to eat, a sort of limits around like the types of foods potentially. You might notice like a sense of avoidance. I mean, all of those things in a teenager would be pretty difficult to spot though, because they're naturally like spending more time with their friends. So you're not necessarily having dinner or at their activities. So, I think it could be really tricky to spot. These are also, I think, similar to other kinds of addictions. They're really secretive. The behaviors are pretty secretive.
I thought to ask, you mentioned hiding food earlier, and so is that an indication? But when I go into my 12-year-old's room, she's hiding candy, but that's because I won't let her have candy all day.
Yeah.
And so it's, how do you decipher between a normal behavior versus a problematic one?
Yeah. I don't know in that case. I mean, that's a pretty normal behavior for a kid to have.
Yeah. Makes me crazy.
I know.
You're such a meanie.
I find hundreds of wrappers of candy, and I'm like, if you just ask me to have some once in a while.
Yeah. I mean, it's also an opportunity to have a conversation about it.
Like, yeah. Why are you doing this?
I don't know if this would have an impact, but you could be like, okay, maybe I need to rethink the way I'm kind of, allowing sugar, just like what's that dynamic? And there are some people who think that, there's sort of this intuitive eating movement. And I remember working this dietitian years ago, and her philosophy was sort of like, just to really let kids kind of have whatever they want. Well, I have an 8-year-old, and I don't think that he knows how to regulate. So he needs support in that. But I do think, including in their overall nutrition, like, okay, fun foods. And, he snuck away with a can of Nutella with a friend, and they were eating it on a bed, and I was like horrified.
That has happened in my house.
There was some like finger smudges everywhere.
It was
telltale
funny.
Signs.
After I said, "Why are you doing that?" I thought to myself, "You can't say that to your daughter, Allison. She'll totally lie to you and panic." Because it's such a delicate. But I've totally found. See, my kids think that if it goes in the trash in the bathroom, it suddenly disappears into this like secret portal somewhere, and I never see it.
Yes.
So they put like the empty jar of Nutella and the silver spoon in the trash.
Yes, totally. I mean, I think that's what's so tough about this is that like, there's no like perfect eater,
Right.
I think it's like,
that's right.
we're all just, have weird relationships with food. So I think that's something I talk to my clients a lot about, that like the goal, because I think sometimes like because they have a lot of shame and they are kind of like just seeing it from one lens, they kind of see themselves as having trouble with food, and then they forget like that other people are trying to navigate this and, you know, in various stages of, you know, like issues, but not clinical issues. But just to encourage them that like we're not trying to get to 0% eating disorder or even like some kind of perfect kind of eating. We're just trying to get to like normal levels of neurotic. And, you know,
that means
like
New Yorkers? No.
it just means like, you know, you're gonna probably like, I think I don't know a person who doesn't have, you know, some kind of like just stuff around food, you know.
Absolutely. Absolutely. You know, I'm going to interject because, again, what I see coming through my office is often I'm going to focus on the young woman whose mother has brought her in to say she hasn't had a period in over 6 months.
Yikes.
That's often kind of the trigger to get them in the office.
Yeah.
And then, you know, when we talk about signs and symptoms, so just to clarify that, so young women who lose a lot of weight will often stop having their periods. And that is kind of a trigger for the rest of the body to have changes as well. There's a risk of a bone demineralization. There are signs and symptoms like thinning of hair, change in the contour of nails. All of a sudden, this young woman might be just so fatigued because she is literally not getting enough nutrients and sugars, good sugars in her diet to propel her through her day. So just overarching fatigue. These are things that, or they come into my office and I take their pulse and it's really, really slow.
Yeah.
The heart can get affected by long-term food restriction, as you discussed earlier. So in a way, it's kind of easier, for lack of a better way of putting it, when someone comes into my office, because the menstrual cycle absence is such a kind of it's not the only reason women will stop having their periods, but in a young, slim woman, it's the first question in my mind. I may not say it out loud, but it's the first question I have. Yeah.
You wouldn't say it out loud?
Meaning, no, if I meet them for the first time, no, I will talk about food intake.
Yeah.
I'll talk about what's their favorite food. I try to engage it in a very light fashion because, first of all, I've never met them before. So maybe their body type is, 5'9", and they're always 115 pounds, and they've been that way. So I always ask, if the mother is in the room, or it's rarely the father, but if the mother's in the room, has she always been tall and slim?
Yeah.
And the mother's like, well, not quite so slim.
Yeah.
Or, no, this is her mother, her grandmother, her sister, if her mother looks the same way and the grandma, if there's that genetic propensity for that kind of body type, it just gives me a slightly nuanced feeling around what might be happening versus the culture of the family is of eating full meals, kind of a full body type, and the daughter walks in and she's really looking quite different, and moreover admits, because they almost always admit to having lost some weight. They don't tell always the truth around how much, but they're like, yeah, I've lost a few pounds. There's also the way they dress. Often these young women will come in with very flowing, big hoodies, big sweatpants. So you can't really see their body.
Yeah.
They often don't want to be weighed, and we never force anybody to be weighed.
Okay.
It's just a kind of a constellation, but I might not say at that first visit, I'm worried about you eating.
Yeah.
I will say, I need to make sure you come in 2 weeks. I make sure my nurse has gotten a height, a weight, just even maybe had put her fingers around the person's wrist to see where her fingers overlap. Very informal. That's not medicine. That's just kind of an informal way of touching somebody. And then have them come back in 2 weeks. And then we start to kind of dive deep into that. Or I might ask the child to leave the office and just talk to the adult and say, is she demonstrating any change in the way she's eating or what she's eating or whatever?
Yeah. Yeah, that's tough. I mean, I'm usually interacting with clients, I mean, later in the process, just having been at a treatment center for so long.
Yeah.
But I do think then it's, it would be good for a parent to just consult a professional and really, I think there are some small things that you can do to try to assess. So I think the first one in that situation is like, if you try to increase their intake, just plating them a little bit more, how do they respond to that? And you can do just like a small kind of test of that, trying to kind of get a little bit of information. A young person may not have tons and tons of insight, or they might not have the language to be able to talk about it.
Yeah.
With like 12, 13, 14, even teenage. Yeah.
17.
I mean, it's like they think they're getting in trouble.
Right.
They
get very nervous being monitored and asked.
Yeah.
And
Yeah.
It's very strict. I mean, that's why, like earlier I said, I don't even dare try to treat them. I go to the person that is the professional and has the additional training in the area, because it can feel so invasive, and then they shut down, and then they don't get treatment, and then it just can become much worse.
Yeah. In my early training, I remember, there was so little known, and not a whole lot more now, but it was one of those diagnoses in the clinic that you just felt so powerless.
Oh, yeah.
And hopeless around.
Yeah.
But one of the things that used to be a descriptor for the woman with anorexia was, the straight A student, controlling, good girl. And I that whole description kind of bothers me on a lot of levels.
Yeah, I was just going to say.
But is it still, well, that's how I was trained. That's how I was trained.
It.
Yeah.
No, and I believe it. And I think back to, Freudian perceptions, which are, most of them are ludicrous at this time. But how interesting that we find a woman that is successful and this and that is why she must have this disorder, this problem.
Is that discussed still in that
I think the language is a little bit different. So there's a relationship between, there's like an OCD kind of presentation and a lot of people who then become rigid around food. So, I think, there's a little bit of a caricature, that happens, but there are things about it that are like vaguely correct, just high perfectionism. I mean, that is a profile that exists, a person who's kind of wanting to perform at a really high level. They sort of like are very, very goal oriented. They're able to kind of put other needs behind their kind of goals and ambitions. And that can be problematic because they can sort of not be tracking their body or their need to slow down or their need to eat, or they get kind of locked into a sort of, pattern of eating, but the sense of like everything needs to be under control.
Right.
Everything needs to be just this right way. And I mean, I think of that as also is like a little bit of a brain problem in the sense that they have difficulty kind of, shifting priorities when it's called for.
Yeah.
Yeah. And that's just like a temperament, really. But there's all different kinds. I mean, there are people who have, ADHD who are vulnerable to developing eating disorders. And some of that is like, just like tracking the body, for different reasons.
Yeah.
Or I've seen a number of clients over the years where they had a early diagnosis of ADHD, were put on stimulants that had a appetite suppressant effect. There was some kind of weight loss. And then kind of the physiological process of the eating disorder started. And then there was, once you come down from the stimulant, there's hunger. And then they would overeat and then get freaked out. It's just like a whole cycle. So I've had a lot of those kinds of clients over the years.
Yeah, and those medicines are being used a great deal these days.
Yeah. I guess there's one thing I wanted to say that Allison kind of was talking about earlier, which was sort of about like, so when I treat clients, there's always the target of symptom reduction. That's always there if they have an active eating disorder. But really, whatever their problem is, we try to kind of locate, some kind of, symptom reduction. So whether that's anxiety, whether that's, whatever. But I feel like, Allison, you were mentioning this kind of the way in which some of the like psychology of a preoccupation with food and body can function for people. Mm-hmm. So, it can function as like a repetitive thought that is almost like a safety behavior that they keep going back
like
to.
Like a stimming.
Yes. Yeah.
Right.
So
Can you explain that? Can you explain that?
So stimming, for example, if you were to see it in the physical sense, is very common in people with autism or severe anxiety. And it can be rocking back and forth. It can be biting nails. It can be the twirling of the hair. It's a repetitive motion, very similarly to even infants. Infants stim healthily, sucking their thumb, rocking themselves back and forth to sleep. But it's essentially a motion that allows us to calm the nervous system. So when it's a psychological stimming, it becomes like a repetitive thought. And then again, that's not necessarily anything that is, like echolalia, which echolalia is the repetition of something. Like news is on at 9, newscast at 9, newscast at 9. That would be an example of echolalia. But psychological stimming is the neurofiring of the brain kind of loops and loops and loops and loops around the same thought or habit. And though it can be a maladaptive habit, like an eating disorder, there is a comfort in the reliability of the habitual thought process and pattern, and then the action as a result.
Yeah. So it's almost like, let's say, it's like what it looks like in the room when you get into the, into the sort of like deeper kind of psychology of it is it's like this kind of safety behavior that people have. And it's sort of like they take the sort of like big existential problem of just like having a body and being a human.
Not an easy thing.
They make it really concrete and it's like an organizing principle for them. So the thing that's wrong is my body. I mean, that it's not as thought out as this. It's more kind of an impulse. And if the thing that's wrong is your body, it feels like you could do something about that. You could. It's sort of like concrete. Control. It's knowable. But if the thing that's wrong is that you have a body and you're walking around and driving a car, and it's really weird that we all do this, it's like, what is that? It's too big. Just the problem of life is just much more abstract. But the problem of like, of weight is very concrete. The problem of food is like a thing that you can kind of order the universe, or like a lot of clients will do things like weigh themselves compulsively. Okay, well, if you are weighing yourself 5 times a day, do you think you're getting any new information?
Right.
No. But why do they want to do it? Because it makes them feel safe.
Yeah.
Even though it tortures them, they feel a sense of, discomfort, psychically.
Not knowing.
Psychically.
Yeah.
They're not even maybe thinking about their weight.
Right.
It's just like, I don't feel safe in the world. And then they step on the scale just to feel
control.
Yeah.
And I also, in the past, I have described it as sort of like, and I say their dirty little secret, but I don't mean dirty, but it's like their journal, their thing they do, their control, their safety.
Yes.
Similarly to cutting, for example. Yeah. It doesn't have to make sense on the outside, but for them, it's like, okay, in this world where I feel like I'm falling through space, I can feel grounded if I step on the scale because that's my check-in. That's my safe space. That's my go-to that makes me feel associated, essentially, and connected to the body and the world. So it's really like, it's like their little, I'm sort of gesticulating over here and trying to use my hands to explain something, but it's like, it's like their little lockbox of safety.
It's the way they're regulating their mood, really.
Yeah.
You know, the other thing is that like a lot of the behaviors, binging, purging, and restricting, they have a sort of physiological impact, so they can tamp down anxiety. I mean, they are effective for people. It's just that they, lose their effectiveness. They're sort of short-term effective, and then they create this cascade of all these other problems.
So a conversation I've been having quite a bit with other moms, other parents, is that the kids right now, I mean, I'm talking about even kind of under 30, that they just they're struggling because the world is a mess. And they look at what's happening to the earth. They look at what's happening in politics. They look at it feels like, at least personally, I feel like, what's working? I don't know, other than Vulva Views, and our podcasts. I hope they're working. But, they feel so out of control.
Yeah.
And so more and more parents are talking to me about their kids needing therapy, needing medications, kind of getting lost in the shuffle. And I'm wondering, are you seeing more eating disorders as a result or in relationship to the chaos of our times? Or are there always chaos? And is there always, it just feels like it's a heavy time right now. And maybe it's just me or, who I'm speaking with. I'm just curious.
It's hard to say because I've always seen a lot of eating disorders.
Yeah. No,
So, but I have had, I see a lot more eating disorders where there's kind of this, what I would say is like an OCD component. And there can be these preoccupations that are sort of about like natural disasters or, planes are always a big preoccupation for people, but things that are related to, kind of concerns about global warming or even like, potentially like political conflict.
Oh, yeah.
Yeah, it's certainly on people's minds.
Yeah.
But I don't know. I mean, I also treat adults. So I don't get a lot of adolescents in my private practice. Over the years, I've treated a lot of adolescents within the treatment context or treatment center context. The ages have been getting younger for a while.
Yeah.
I'm very grateful that you're here because, again, my goal was for people to hear and learn more and be more open and not so judgmental towards those suffering, because this really is a disease and a disorder or a reaction and a symptom caused by something so much greater. So I thank you for your time and your brilliance.
Yeah.
Quite
Tabitha,
frankly.
what
Thank you
you've
so much
done
for
is
having
you've
me.
really helped us understand that it's not like just start eating. I mean, I can't tell you how many times I've heard mothers say to their daughters, just start eating. It is a very complex phenomenon. And you pointed out the physiology, the genetics, perhaps, the kind of the shifting that goes on in the body triggered by a change in the way they approach food. Yeah, or behaviors related to it. Yeah, thank you so much for being here.
Yeah, thanks for having me.
Yeah.
So I have a tiny little quote or some words of encouragement that I dug up from the National Eating Disorders Association. I'm sure that's something that you're very familiar with. So it reads, recovery from an eating disorder can take months, even years. Slips, backslides, and relapses tend to be the rule rather than the exception. Relearning normal eating habits and coping skills can take a long period of time and often requires lots of support from professionals, friends, and family. Moving forward is key. However slow it might be. So just for those suffering, give yourself the time and the patience and go for the correct care and the person, like I said, that is specialized in this disorder to get yourself some help.
And please, for all those parents out there who might be listening, this is not your fault.
Yeah.
There's no one person who caused your daughter or your son to have this disease.
Yeah.
So please, there can be some gentleness to yourself. And I always think that a problem like this is a family issue. And so, seeking someone's help like Tabitha to look at the family unit in addition is so important. Yeah. Thank you for joining us on Vulva Views today. Please, if you have any questions or concerns, let us know. I'm Amy Novatt, MD, gynecologist.
And I'm Allison Chawla, psychotherapist and alternative healer. You are listening to Vulva Views.